So let's start talking about frosted branch angiitis as a review. Let's see what are the outlines that we are going to talk about. First of all, we'll talk about frosted branch angiitis. Is it a clinical syndrome or a clinical sign? And then we'll talk about the classification of a frosted branch angiitis. And then we'll talk about cases of Behcet disease presenting with frosted branch angiitis as a review of literature. And then we'll talk about cases that was seen in Saudi Arabia. And then we'll talk about frosted branch angiitis complicated by retinal vein occlusion. And then we'll talk about retinal vein occlusion like precursor stage for frosted branch angiitis. And then we'll talk about a case report that was seen recently after COVID infection. So, frosted branch angiitis is a rare form of retinal vasculitis which include widespread translucent perivascular exudate that resemble in the appearance of a frost on a tree branch. So, the first question that I would like to ask, do you think that frosted branch angiitis is a clinical syndrome or a clinical sign? Who think that frosted branch angiitis is a clinical syndrome? Raise your hand. No one? What about clinical sign? Oh, almost all of the audience. So to answer this question, let's go through the history of frosted branch angiitis. In 1976, Etiology, he described the first case of frosted branch angiitis. The case was a 6-year-old boy who developed idiopathic bilateral retinal periphlebitis. He described this appearance as a frost in the tree branch. 4 similar cases were reported in Japanese literature. Until 1987, the first case in English literature was reported, and the patient was also a Japanese girl. The following year, 3 patients were reported in North America with similar condition, but the term acute frosted retinal periphlebitis was proposed instead of frosted branch angiitis. All of these reports have a similarity in which the patient was healthy and young, the visual loss was bilateral. For fundus examination, there was a thick perivascular sheathing involving all the retinal veins in both eyes, from the optic nerve to the peripheries. And for the FFA, there was late staining with no abnormalities of the blood flow. And all the patients responded very well to systemic steroid. So at this point, the frosted branch angiitis was considered as a clinical syndrome. Following these initial reports, there have been 7 additional patients who matched this clinical course, 1 in Japan, 4 in the United States, 1 in Turkey, and 1 in India. However, some of these patients, the complaint was, or the finding was only unilateral. Other patients, they have a systemic abnormalities. It's not an idiopathic. Some of the patients, they fail to respond to systemic steroids. Other patients, they have a large cell lymphoma associated with the presence of frosted branch angiitis. Other patients, they have CMV-related frosted branch angiitis, either due to AIDS or post-cardiac transplant. Also, some of the patients presented with acute lymphoblastic leukemia, and there are also 2 reports with Crohn's disease and systemic lupus. So at this point, we have 3 subgroups of patients who have similar retinal appearance. The first group is patients with lymphomas or leukemias in which their frosted branch angiitis is due to infiltration with malignant cells. At this point, we call the frosted branch-like appearance. The second group of patients, they are patients who have viral infection or autoimmune disease. They have a cause for the frosted branch angiitis. At this point, we call the frosted branch angiitis as a clinical sign, and we describe the fundus as a frosted branch response or secondary frosted branch angiitis. For the third group, they are healthy young patients, and they have proceeding like viral-like illnesses. These patients, they represent an immune reaction to a number of different stimuli. Until this causative agent is identified, we will group them under the name of a clinical syndrome, and we will call it acute idiopathic frosted branch angiitis. So the use of the term frosted branch angiitis in literature as both a clinical syndrome as well as a clinical sign promoted the report to distinguish 3 different subgroups based on their etiology. So the first group, as we said, frosted branch angiitis in a neoplastic process. It's a frosted branch-like appearance. The second group is a primary idiopathic frosted branch angiitis, which is also called acute idiopathic frosted branch angiitis. And the third group is secondary frosted branch angiitis due to either infectious or autoimmune etiology. This is the first group, in which it's caused by lymphoma or leukemia, and the appearance of a frosted branch angiitis is due to infiltration of retinal vessels with malignant cells. The second group, which is primary idiopathic frosted branch angiitis, this patient was described as follows: healthy patients, infectious prodrome, acute visual loss, vascular sheathing, and in FFA you will see late staining or leakage, but there is no occlusion, and they respond very well to steroid with excellent visual recovery without recurrence. In this table, they summarized all the patients or the cases that was published until 2003. As a summary for the table, the frosted branch angiitis predominantly was seen in young and fit individuals. They have like a bimodal age distribution, with one peak in childhood and the second peak in the third decade of life. They occur more commonly in females, and most of the patients have bilateral disease, and the most common presenting symptoms was subacute visual loss, flutters, and flashes of light. The visual acuity in most of the patient it can be reduced to perception of light. And for the associated systemic symptoms was flu-like syndrome. So the typical onset of a frosted branch angiitis after prodromal illnesses has led to the suggestion of hypersensitivity reaction to various infective agents, and which may initiate the immune complex deposition as a pathogenesis. Let's go through one of the cases. This is a pregnant woman who's healthy with no systemic association, presented with bilateral frosted branch angiitis. And after she received a course of steroid, her signs totally resolved with no recurrence. So frosted branch angiitis in typical form and associated with pre-existing intraocular inflammation is likely to be a primary immunological process in response to a number of provoking antigens. The third group is secondary frosted branch angiitis due to infectious or autoimmune etiology. They are characterized by frosted branch response to various causes, either infectious or in autoimmune diseases. For the autoimmune disease, now we are seeing more and more patients with Behcet disease who presented with frosted branch angiitis. Let's go through the literature in general, and then we'll talk about cases that was seen in Saudi Arabia. Eye involvement that occur in Behcet disease was from 43 to 65%. Vitritis and retinal vasculitis are the most common manifestation, and there are only 10 cases of frosted branch angiitis in Behcet disease that reported up to the date of 2017. In this table, you will see the characteristic of patient that was diagnosed with frosted branch angiitis as an ocular manifestation of Behcet disease. If you can see in here, almost all of the patients, they have oral genital ulcer and skin lesion, and almost all of them, about 7 out of the 10 patients, they have positive HLA-B51. And for the visual acuity, in most of the patients, after treatment, their visual acuity has improved. Let's go through one of the cases. This is a 30-year-old man with a history of skin and recurrent oral ulceration over 1 year who developed loss of visual acuity in the right eye. The diagnosis of acute frosted branch angiitis was based on the retinal vasculitis associated with retinal edema and hemorrhage. It was confirmed using FFA, in which you can see venous leakage and extensive staining. In here, we can see the pseudofolliculitis and the oral ulcers. In this fundus photo, you will see the hemorrhagic perivascular sheathing and macular edema. And this is after treatment. The patient received steroid and colchicine for the oral ulcers. So let's go through the cases that was seen in Saudi Arabia. So we are conducting a study, but it's not yet published. This is a retrospective case series of 10 patients with frosted branch angiitis and Behcet disease. This table summarizes the demographic data and clinical representation of all the patients. So there are 10 patients from 3 different tertiary referral centers in Saudi Arabia, one from KKISH, one from KSU, and the other is from Dammam. They were evaluated according to the demographic data, clinical presentation, and imaging. The age of the patient ranged from 16 to 47. Almost all of them were males. For the primary presenting symptoms, half of the patient presented with oral or genital ulcers, and the other half presented with ocular complaint as the primary presenting symptoms. For the ocular complaint, most of the patient presented with decrease of vision, followed by flutters. The ocular involvement was bilateral in about 4 out of the 10 patients, and for the presenting visual acuity, it was less than 2200, in about 9 out of the 10 patients. Almost all of the patients presented with anterior non-granulomatous uveitis, vitritis in 5 out of the 10 patients, and retinal vein occlusion in 3 out of the 10 patients, and papillitis in 7 out of the 10 patients. For the OCT, macular edema was seen in 6 out of the 10 patients, and hyperreflectivity of the inner retinal layer was seen in 4 out of the 10 patients. Following treatment, 7 out of the 10 patients' vision has improved, and 3 out of the 10 patients' final visual acuity remained poor. This is one of the cases that was seen in Saudi Arabia. This is a 34-year-old male who came complaining of sudden loss of vision in the right eye. He had a history of fever, oral and genital ulcer before presentation. His visual acuity was no light perception in the right eye and 20/20 in the left eye. This is his anterior segment examination. As you can see in here, there is no KBs, and there are some AC reactions, so it's non-granulomatous anterior uveitis. This is his fundus. The left eye is normal. In the right eye, you will see the hemorrhagic perivascular sheathing that's involved all the 4 quadrants. And in FFA, you will see the delay of central retinal artery perfusion and the blockage effect by the hemorrhage. In OCT, you will see the loss of normal retinal layer lamination and the hyperreflectivity of all the retinal layers. The left eye, here the OCT is normal. This is the first case. The second case is a 28-year-old male with a history of fever, oral and genital ulcer. He came complaining of decrease of vision in the left eye to hand motion for 3 days. As you can see in the fundus, hemorrhagic perivascular sheathing that's involving all the 4 quadrants, resembling the frosted branch angiitis. And for OCT, you will see the loss of retinal layer lamination, hyperreflectivity of all the retinal layers. In FFA, you will see the delay of inferior retinal artery perfusion. And this is after treatment. The patient received oral steroid, Humira, and multiple injections of Eylea. This is another case, which is a 16-year-old male who came complaining only of flutters that started in the right eye and then shifted to the left eye for 1 month. His visual acuity is 20/30 in both eyes. As you can see in here, the thick perivascular sheathing involving both eyes. For OCT, it's drying centrally. However, if you take a look at the cut over the frosted branch angiitis, we'll see the thickened perivascular sheathing that's compressing in the inner retinal layer and forming like a wave, and it formed like an outer plexiform layer elevation. And this is after treatment. The patient received oral steroid, Humira and Imuran. And as you can see in this picture, the OCT is dry and resolved with the perivascular sheathing. However, there are some area of persistent of outer plexiform layer elevation. And this sign was mentioned in literature that it's significantly correlated with the number of Behcet attack or Behcet activities. Now let's talk about the relationship between frosted branch angiitis and retinal vein occlusion. Do you think that frosted branch angiitis can lead to retinal vein occlusion? Yes. Who think? Okay, about half of. What about frosted branch angiitis? Do you think that retinal vein occlusion can lead the opposite way around? No, 1, 2, 3, good. And then do you think that they can occur together at the same time? Okay.
Yes.
Oh, okay. So to answer this question, is frosted branch angiitis can lead to retinal vein occlusion? Let's go through these two articles. The first article, which was published by Prof. Abu Asrar in 2003, in this report, they describes two cases of fulminant retinal periphlebitis resembling frosted branch angiitis associated with non-perfused central retinal vein occlusion. Despite systemic steroid and full PRP, MVG occurred and the visual acuity worsened in both cases. In this picture, this is the photos of the first patient and this is the second patient. The two patients were young, adult, and both developed frosted branch angiitis. The periphlebitis was followed by in patient number 1 and was associated with non-perfused CRVO in patient 2. Both of the patients, they were complicated by ribose iritis in both cases and new vascular glaucoma despite full PRP and steroid. They have found that systemic steroid appeared to be effective because the perivenous infiltrate were reduced and then disappeared in response to steroid. However, CRVO progressed and new vascular glaucoma developed. There are some important points that we should mention. That patient number 1 had raised level of IgM anticardiolipine antibodies, and patient number 2 has a positive lupus anticoagulant, and this will indicate this indicating the involvement of antiphospholipid antibodies, which is known to be associated with arterial and venous thrombosis. The association between antiphospholipid antibodies and retinal venous occlusion was previously reported and it's well known. This table we'll see the previously reported cases of retinal periphlebitis associated with central retinal vein occlusion. If you notice that almost all of them ended with a poor vision. However, if we dig deep in the cases, we'll find that the central retinal vein occlusion was non-perfused CRVO, and for the treatment, they did not use anti-VEGF at that time for the new vascular glaucoma. They used PRP and systemic steroid. Now let's move to the next article, which is about frosted branch angiitis complicated by retinal vein occlusion as a clinical cause and long-term visual outcome. The aim of that study was to describe the clinical course, long-term visual outcome of 3 patients who developed retinal vein occlusion and macular edema as a complication of frosted branch angiitis. Their methods was descriptive case series. So 3 young healthy patients, aged 22, 37, and 45, they presented with sudden visual disturbance secondary to unilateral primary frosted branch angiitis. They improved significantly following high dose of steroid therapy. Several weeks later, RVO developed with marked cystoid macular edema. The visual improvement was achieved and maintained with anti-VEGF over a period ranging from 14 to 44 months. In the 2 cases, they used anti-VEGF treatment. So at the presentation, in one of the patients, we can see the diffuse retinal vascular sheathing with vascular tortuosity and macular edema and optic disc edema. 4 months later, there is diffuse flame-shaped retinal hemorrhages with a few cotton wall spots and vascular engorgement and optic disc edema. This is another case in which you can see the typical frosted branch angiitis, the hemorrhagic frosted branch angiitis. So inflammation-induced thrombosis is a feature of systemic vasculitis such as Behcet disease, especially during the active stage. Behcet disease may be considered as a model of inflammation-related thrombosis, as both venous and arterial thrombosis can occur. This has an important consequences in terms of management and treatment, as immunosuppressive therapy rather than anticoagulation and antiplatelet therapy is required for the treatment. So frosted branch angiitis may be considered a risk factor for development of secondary retinal vein occlusion because of severe retinal vasculitis that eventually leads to activation of the coagulation system and retinal thrombosis. So the second question, can retinal vein occlusion lead to frosted branch angiitis? To answer this question, let's go through this article and then we will see a case that was provided thankfully from Dr. Suleiman. So central retinal vein occlusion-like appearance, a precursor, is it a precursor stage in evolution of frosted branch angiitis? And here we have a 28-year-old Indian man who presented with optic disc swelling, hyperemia, peripapillary hemorrhages, and dilated tortuous veins in left eye. 6 months after being diagnosed with idiopathic frosted branch angiitis in the right eye, within 3 days of presentation, the left eye developed frosted branch angiitis, which was promptly treated with oral steroid. This is at the presentation. I want you to concentrate on the left eye. At the presentation, the patient presented with tortuous veins in the right eye with hyperemic optic disc and perivascular sheathing. For the left eye, you can see only hyperemic optic disc with slightly tortuous blood vessels and a flame-shaped hemorrhage. And FFA, we don't see any leakage in the left eye except for optic disc leakage. 3 days after initial presentation, the same eye, the left eye, you will see increase of optic disc edema with hyperemia and thickened perivascular sheathing along the major blood vessels. And this is 4 weeks after treatment. The next case, this case was one of Dr. Suleiman's cases. And here we'll see combined central retinal vein occlusion, ciliary-retinal artery occlusion that was precursor for the development of a frosted branch angiitis. This is a 25-year-old healthy male presented with sudden paleness, visual loss in the left eye, with a visual acuity of 2300. Fundus exam and fluorescent angiography showed signs of combined CRVO and ciliary-retinal artery occlusion. Without a treatment, his vision gradually improved until it reached 20/30. This is at presentation. We see the hyperemic optic disc, tortuous blood vessels, and ciliary-retinal artery occlusion. And here we see only leakage of the optic disc. In OCT, the cut was taken at the area where the ciliary-retinal branch occlusion occurred. You see the reflectivity of the inner retinal layers. This is at presentation. After 4 months, the vision dropped to 2400 in the same eye, and a clinical picture of severe occlusive periphlebitis resembling a frosted branch angiitis associated with severe macular edema. So in here you see the typical frosted branch angiitis, the extensive perivascular sheathing involving all the 4 quadrants, and in FFA you'll see the area of capillary dropout and non-perfusion, and in OCT you'll see the extensive macular edema. So this was treated successfully with anti-VEGF injections, systemic steroid and immunosuppressive medication with sectoral laser. This is post-treatment, and at this stage the patient vision reached 20/25. So a CRVO-like picture may be the first stage of frosted branch angiitis. Young patients with CRVO-like picture may progress to frosted branch angiitis. Therefore, a high degree of clinical suspicion and early follow-up is required for young patients who presented with CRVO-like picture and signs of anterior or posterior segment inflammation for early detection and timely management of frosted branch angiitis. So we will conclude with this case. This is a frosted branch angiitis presenting after COVID infection. Less than 4 weeks after COVID infection, a 10-year-old female presented to the emergency department with severe headache and intermittent fevers. During her hospital stay, the ophthalmology service was counseled for blurring of vision. Subsequent eye examination revealed frosted branch angiitis, as you can see in here, the thick perivascular sheathing. The patient initially received intravenous steroid, but it did not respond at the beginning, and it was escalated with plasmapheresis to achieve resolution of her symptoms. Outpatient maintenance therapy was considered as oral steroid and infliximab infusion, and this is post-treatment. So important points to be mentioned: that a prior infection with COVID may represent an important cause of frosted branch angiitis. The clinician should include questioning and testing to evaluate the possibility of recent infection when investigating this cause of retinal vasculitis. Lastly, when intravenous steroid fail to improve symptoms, escalation to plasmapheresis may be necessary to achieve the resolution of symptoms. So as a conclusion, frosted branch angiitis may be associated with infectious, non-infectious, or idiopathic causes. An extensive workup should be done to exclude systemic associations. Prior infection with COVID should be considered in differential diagnosis, and treatment with systemic steroid must be initiated, especially in association of the causes and for inflammation control and blindness risk reduction. And thank you so much.